Hello guys, welcome to our channel. Today we will be discussing the as part of the Mission 200 plus Orthopedics Rapid Revision guys. So we will be discussing all the important topics of the orthopedics that should be revised for the upcoming examination. Those who are new to this channel, please do subscribe and share with your friends and do like the video so that it will reach the many students, those who are preparing for the upcoming examination. So if you want to avail the notes, please do join the group and follow the steps given in the comment box. Next. So let's start the discussion guys without the delay. So here the one of the best scientists and who has contributed their entire life for the orthopedics research. So one among them is you all have know that is also one of our important topic, that is Salter and he is Harris. So Dr. Harris and Dr. Salter, who has contributed many discoveries. For example, one of the classification is a physical fractures, right? Physical growth fractures that has been described and discovered by these two important scientists. So they are the pediatric orthopedic surgeons. So that was one of the greatest contributions from them. So let's start the discussion, guys. So before we go into the fractures and important points, let us know something about the most important points about the orthopedics basics. Okay, so from the structure you have to know there are the three important structures, that is here you can see this is the epiphysis and this is the metaphysis and the shaft of the bone, which will be consist of the diaphysis, and metaphysis is contains the spongy bone and diaphysis which will be contains of the compact bone. Okay, and inside this yellow bone marrow, which will be very important for the our blood cells and the importance of the red bone marrow, and here also we will be having the RBC production, right? This is the importance of the basic structure. And whenever you are looking that, there will be important the layer, that is the periosteum. What does this periosteum will do? This periosteum will be connecting the main bone and to the outer layer to the surrounding structures. And what are those structures? That is between the bone and the periosteum. Between the bone and the periosteum we have the sharpening fibers. Okay, these sharpening fibers from the periosteum layer and to the bone, it will be connecting. That is the important point. Next, this question has been also asked guys. The sharpening fibers is where it is presented between the bone and the periosteum, the covering layer. Next, important point, what are the cells is presented, what are the inorganic material, what is the organic material. So in organic material, when I say inorganic material, we have calcium hydrophosphate, hydrophosphate sorry, hydroapatite. Next we have the organic material. Organic material means different types of the cells and proteins, collagens. For example, we have the type 1 collagen, right? All the important tendons, fascia and the bone, which will be consisting of the collagen 1. Next, along with that, we also have the important part, that is the pro-collagen. Okay, we also have the pro-collagen, which is gives the more and more importance to the bone formation. And what are the cells we have? We have abundant cells, those are osteophytes. These are the mature blast cells. These are the mature cells and most abundant cells. Okay, always in the resting but most abundant cells. Next, osteoblast. Blast means it is bone is whichever is maintained, such as bone matrix, that is happened with the formation of the osteoblast, and it consisting of the ALP, important enzyme. Next we have the osteoclast. Okay, osteoclasts which act as a macrophages. If even if there is any infection, this osteoclast will be working. But if you want to activate the osteoclast for the bone resorption, okay, for the bone resorption, where you have to connect. So we have the osteoblast. So these osteoblast will be consisting of the rank ligand. Okay, these rank ligand which will be activating the osteoclast, which will be activating the osteoclast. This is the point that you have to remember guys. Next, moving on to the fracture healing, right? So before that, you also have to understand what is the fracture. Fracture means the bone has been broken. Okay, so whatever that layers we are seeing here, that might be broken. It could be complete or it could be incomplete, but it is due to stress fracture or it could be due to pathological fracture. So stretch fracture, that means this is normal bone. Pathological fracture means it is a disease bone, right? This is the main difference, right? For example, if you have sudden RTA, that will be having the stretch fracture. If you're having any osteoporosis, that will be considered for the pathological fracture, right? And how the fracture healing will be done. So that is required. So there is a first hematoma formation, and followed by the hematoma, you will be having the callus formation. And these callus will give the strength to bone to regenerate more. And the callus will be ossified. Okay, so this is the extra articulate callus. And after this extra articulate callus is formed, it is going to use for the ossification, and later on it is going to cause the bone remodeling. How many weeks it will take? It will take even years. For example, the hematoma formation within less than 1 week, and the week 2 and 3, that is callus formation, and callus ossification is 4 months, and up to 12 months there will be bone remodeling that we are going to see, right? And if ever it is not formed, what happens? There is a complications such as malunion, or it could be due to non-union also. So what are the factors that is affecting the malunion and the non-union? And most common cause for the malunion is mostly this is due to reduction defect. Okay, so the doctor who is operated or the cast who has applied, so the reduction is not properly done. So that is why the patient has got the malunion. And where you are going to see this malunion? Malunion is mostly due to wrong positions, right? So these wrong positions is usually associated with the Smith fractures. Okay, this will be associated with the Smith fracture, but the most common cause is the improper reduction. Next, coming to the non-unions. So the non-unions is most commonly due to the patient might have the problem. Okay, so the patient has the displacement. Okay, displacement could be, or reduction is not done properly, or patient has some of the immune processes. For example, improper callus formation, for example, improper hematoma formation. All this will be going to cause the non-union, and one of the example is the scaphoid fracture. Okay, scaphoid fracture, this hashtag will be considered as a fracture, guys. So just remember, when I am adding the fracture, that will be denoted as a hashtag. Okay, so this is the main difference between the non-union and the mal-union. And how you are going to differentiate, guys? So there is a callus formation, and here there is no complete callus formation. There is no complete callus formation. What about the treatment here? In the mal-union patients, usually this is due to improper reduction. So you have to correct it. Okay, you have to correct it. For example, non-union. So for this patient, we can attach the autologous graft. Okay, attach the autologous graft, that can be also given for these patients of the malunion. Next, there will be acute complications whenever the fracture is happened. If it is a major fractures, so the patients will be having the separate kind entities that will be going to cause these patients. One among them is the fat embolism. Okay, fat embolism question has been asked many times, so should not be ignored. So fat embolism is due to fracture due to femur fracture. Okay, so the major fracture will be femur. So what happens whenever there is a femur fracture? So the blood is increased, right? The circulation will be increased, and from the femur the bone is broken in the closed space. This will be releasing the medulla. So this medullary cavity, here you can see, so this medullary cavity, whenever it is broken, it is going to also release the fat. Okay, so this will be releasing the fat. So when this fat is entered the circulation, whenever this enter the circulation, it can travel, right? Small vessels, large vessels, it can travel to anywhere. And what is the onset? Onset will be less than 24 hours. Onset plays the major key role. And how the patient will be presented? So the patient will be presented with rash, and also patient will be presented with the tachypnea, because this is an emboli. So the patient will be having the symptoms of the tachypnea and depression. So the irritability will be also decreased. The patient might be lethargic, stupor, or comatose also. And what is the criteria that we are used for the patient diagnosis, that is a GERDS criteria. So don't have to be know about the complete criteria, but what we can do is the mechanical ventilation has to be attached for the patients. And what is the most of the investigation of the choice, that is the patient can have the angiography. Okay, this is how we are going to follow the protocol for the fat embolism. Next, we have the another important complication. So this question has been asked in the recent INCT examination also. So that is the compartment syndrome. What happens when the patient is suffering from the compartment syndrome? So compartment syndrome is always closed fracture. If it is open fractures, we cannot say this is a open is no pressure, right? So compartment syndrome is increased pressure inside the closed spaces, that is due to closed fracture. How much pressure has to be noted so that the patient is suffering from the compartment syndrome? That is 30 mmHg, at least equal to or more than 30 mmHg. Then we have to say that the patient is suffering from the compartment syndrome. And how the patient will be presented, guys? Mostly remember the piece. So first and foremost, the patient will be having the severe pain. How many medications you may give? At least 3-4 analgesic. Also the patient will be having the severe pain, and the patient will be having the pallor because of compression to the circulatory vessels, and puffiness. Okay, puffiness is seen. Paresthesia, because the nerves are also going to compress here in this patient. And ultimately, the late sign. Remember, the pulselessness is not the early sign. This is the late sign that is going to see. And what is the treatment that we have to do? The treatment that we can do is immediately fasciotomy. Okay, relieve the space. Okay, relieve that pressure by breaking the fascia. That is the fasciotomy, and treat the underlying cause, which are the condition. So this is a mostly clinical condition only, and unless or until we are going to use the machine to test the pressure. So this is the treatment for the patients who are suffering from the fasciotomy, right? So these are the two important classifications that you have to remember. Another one, we have the DVT, and DVT is rarely seen. The DVT is rarely seen, but it is also seen less than 24 hours, or it can be presented more than 48 hours. Okay, it can be presented more than 48 hours also. Mostly it will be seen in the calf region, and venous system is involved. Okay, venous system is involved. And what is the treatment of the choice for this patient? Etiplase. Okay, etiplase can be given for the dislodge this thrombus. That is the treatment for given for this patients of the condition. Next, something that you have to remember, what is the markers that we use for the bone? Okay, what is the markers that we are going to use for the bone? So they are the bone formation markers, and they are going to be the bone markers which is associated with the bone resorption also. We will be seeing the different types of the markers, guys, and this question has been also asked in the examination. So first and foremost important, so they are bone formation, and they are bone breakdown. Okay, we can say resorption. So bone formation are such as procollagen, right? Collagen plays the major role. Next, osteo. The names will be also with the osteocalcin, osteonectin. Okay, these are the two important. Next, the bone resorption, these are N and C telopeptides, N and C telopeptides, and there is other one, that is a trap. So what is the trap? So the trap is a tartrate resistant acid phosphatase. This is also going to have. Next, what about the ALP? ALP comes under the bone formation or the bone resorption. ALP comes under the bone formation. So that's why whenever the patient is having the bone resorption, so the patient will be having the ALP increased, right? Bone formation, if it is excess bone formation, that is going to increase the ALP. In that ALP, the most specific is the beta ALP. Okay, beta ALP is the most sensitive one. Next, moving on to the different types of the fractures that we are going to see. So what is the Bennett fracture? What is the Rolando fracture? Let's see both. So first we have the Bennett fracture, and other one is the Rolando fracture. So the Bennett fracture is due to the first metacarpal. Both are going to be the first metacarpal only. But the Bennett fracture is polar ulnar attachment. So this is polar and ulnar attachment. Okay. So first metacarpal base. Right. Next, Rolando fracture. Rolando fracture is also same, but so these will be having 2 to 3 fragments extra. Okay, 2 to 3 fragments extra. Same first metacarpophalangeal base. Okay, metacarpophalangeal base, and that first metacarpophalangeal joint. What is this, guys? This is just nothing but the thumb only. So the thumb which will be damaged, and in both also there is a muscle, abductor pollicis longus. Okay, abductor pollicis longus. Here also abductor pollicis longus muscle will be affected. Okay, that muscle is also affected here. So here you can see the Bennett fracture is only one fragment, but the Rolando fracture, it is going to be more than multiple fragments will be seen at the both are going to be at the base region only. Next, coming to the angle. So this is the angle. So where you are going to see these are your tarsal bones, right? This is your thallus, calcaneum, and navicular. All these bones are present here. So what is importance of this triangle, this angle? So this is known as a Bohr's angle, Bohler's angle. We can say these Bohler's angle is important for this, especially the fractures of the tarsals. Okay, tarsals fracture, which is important for the Bohler's angle, the body of the tarsals. Okay, the body of the tarsal bones fractures is important to differentiate between the fracture lines and also the stability of the surrounding structures such as the ligaments also important play role. Next, moving on to the other important named fractures. So here you can see here this is the fracture. Okay, so that means the patient is having at the second metacarpophalangeal, sorry, metatarsal phalangeal joint. So this second MTP or third MTP is most commonly, so the patient is seen in the patients those who are suffering from the March fractures. Okay, this is seen in the March fractures, especially in the army individuals, right? This is seen in the army individuals. Next, here you can see this is the fifth one, right? Fifth metacarpophalangeal joint. This is seen in the boxers. Okay, so that is why it is named after the boxers. This is the boxers fracture, and this is the March fractures. Next fracture, here you can see another picture. So this is your calcaneum. So on the calcaneum the fracture has been noted here. So this fracture is seen in the patients of the calcaneum fracture, especially in the high heels. Whoever who uses the high heels now, if they have the slip, they can see this calcaneum fracture. This other name of the calcaneum fracture is a lower fracture. Okay, this is also known as a lower's fracture. And we also have the many other fractures related to the, let's see some other important names that you have to know. One is Jefferson fracture. Jefferson fracture. Jefferson fracture is seen in the spine, especially the first C1, that is a cervical. Okay, cervical first vertebrae atlas, right? This is seen in the atlas. Next, we also have the hangman fracture. Hangman fracture. This is seen in the C2 axis. Next, we also have the chance fracture. Chance fracture. This chance fracture is seen in the thoracolumbar. Those who are suffered from the vehicular accident or the seat belt injury. And we also have the bumper fracture. So bumper fracture is seen in the tibia, again vehicular accidents. So these all are the named fractures specific causes, right? Next, moving on to the important images that has been asked as for the tractions. So this is for the gallows traction. Okay, this is the gallows traction used for the children especially. Next, this is a simple skin traction for the immobilization, and same as here, this is also for the immobilization. This is the skin traction with the adhesive tape and the bandage that we are going to use, and this is the Thomas splint. This is how we are going to stabilize and immobilize the patient, and skin traction with the bandage inside too. So these are the different types of the patients who has taken for the immobilization after the immediate fracture. Next, what are the images that you have to identify? This can be also asked. And what is this splint here? Here you are seeing this is the knock bender splint. Okay, knock bender splint, or we can also say this is the knuckle blender splint, and this is used for the patients of the claw hand. Okay, claw hand, where you are going to see the claw hand, especially the patient is having the ulnar palsy. This patients you are going to use the claw hand. Next, this is the Boston brace. Okay, used for the scoliosis, vertebral abnormalities. Next, this is the aeroplane splint, those who are having the brachial plexus injury, right? The patients, those who are suffering from the brachial plexus roots, trunks, they can use this brace. Next, another brace, this is also known as a Taylor brace. This is the Taylor brace used for the Potts spine or associated with the TB spine. Okay. Next, this is the another type of the brace. This is known as a Milwaukee brace, used for the scoliosis, okay, or the any other spinal abnormalities. Next, this is the cock-up splint, and cock-up splint is used for the wrist drop, where you are going to see, guys, this is seen in the radial nerve palsy, right? These all are going to be important and previously asked questions only, so should not be ignored. And in the orthopedics, after the fractures, the most important part is the tumors. Okay, the tumors are going to be most important part, should not be ignored. And in the tumors, you have to know some of the important points. What is the most common benign tumor, and what is the most common malignant tumor? Okay, so these are the important points. So one of the most common benign tumor, that is the osteoid osteoma. This is the most common benign tumor. And what is the most common malignant tumor? That is the metastasis. And if you don't see the metastasis as an option, you can choose the multiple myeloma. And if you don't see the multiple myeloma also, you can choose the option osteosarcoma. You can choose as an important points for the malignant tumors. When I say metastasis is due to multiple types, right? So the metastasis can be associated with prostate in the male, and in the breast will be from the female, right? And prostate is most commonly, so prostate is coming from the blastic phases, right? Blastic type of the osteo. Next, breast is coming from the lytic type, or it sometimes it can be coming from the blastic and lytic also. The most common is the lytic. And where it is coming from, this is coming from the Batson's plexus. And where is the location, the common location you are going to see? Thoracic. Okay, thoracic vertebrae that you are going to see. Thoracic vertebrae is the most common location, thoracolumbar. This is the overview of the general information. Okay, this is the true benign. We have the only benign also. True benign is different from the only benign. So if they ask what is the only benign condition, then you have to choose the osteochondroma. Osteochondroma is the only benign disease that is most commonly seen in the patients. Okay, this is, but in the complication, this can progress to malignancy. This is the benign tumor only, easily treatable, but this can be progressed to the malignancy, that is known as a chondrosarcoma. That is chondrosarcoma, that is also seen in these patients. Next, coming to the true benign tumor, this is the osteoid osteoma. Where is the most common location, guys? That is seen in the diaphysis of the bone. And if you observe, this is seen in the lower limbs, right? This is seen in the tibia or the fibula, and here the lesion that you can observe here. And usually this is seen in the 10 to 20 years of the age group, 10 to 20 years of the age group, and significant they have the pain. So these pain will be subsided with the taking of the drugs, that is the NSAIDs. When the patient is taking the NSAIDs, the pain will be resolved. So this is a classic history that the examiner will be mentioning, and you will be ordering the patient for the X-ray. On the X-ray, you are going to see this lesion that is known as a nidus. Okay, that is known as a nidus, and 2 centimeters. If it is less than 2 centimeters, mostly this is a less than 2 centimeters. If there is a more than 2 centimeters, then you have to do the biopsy and rule out the malignancy in this patient. And what is the treatment of the choice? The treatment of the choice for this patient is the radio frequency ablation. Okay, radio frequency ablation, and most of the times it is a only benign tumor, true benign tumor, no malignancy is seen, and it in the recurrence rates also less only. Next, enchondroma, and enchondromas is mostly involves the metacarpals. Okay, enchondromas is always or the mostly involves the fingers, metacarpals, and the carpal bones, and these metacarpals is associated with the syndromes. One is Maffucci syndrome, and other one is the Olliar's syndrome. Olliar's syndrome. In the Maffucci syndrome, the patient will be having the enchondroma. Along with that, they will be having the multiple other also. For example, lymphangioma is seen in this patient, and hemangioma is seen. So these kind of will be presented in the patients of the enchondromas of the Maffucci. And Olliar's, there will only have the enchondromas and multiple. Okay, not just one. There will be multiple tumors that will be seen. And if it is associated with the malignancy, if the patient is developing the malignancy, so highly the patients will be developing of the chondrosarcoma. Chondrosarcoma. Okay, this is what how the enchondroma is described. Next, coming to the osteoclastoma, this is known as a joint cell tumor. This is involves the epiphysis of the bone, right? Classically, epiphysis. Here you can see this involving the epiphysis, and on the X-ray, it is going to show the soap bubble appearances. So bubble appearances that you are going to see, and on the examination you may heard the eggshell crackles on the examination, and this is associated with the translocations. This is associated with the translocations 12 and 22. Some of the translocations trisomy 21 12, like that also it is going to be associated with the translocations. And when you do the biopsy, you are going to see the giant cells. Okay, the giant cell tumor, which will shows the giant types of the cells of the osteophytes, will be seen in this
These are
patient.
the
And
important
treatment,
points
you have
and
to
the
do the
diseases that we have to
extended
remember in this
curettage.
condition.
Okay,
Those who are
not the
new to this
excision,
channel,
guys.
please do
This is
subscribe.
extended curettage has to be done, and after curating this, you have to fill that part with the cement or the cast. That has to be done to prevent the recurrences in the patient. Next, moving on to the malignancy tumors, as I said, what is the most common? That is the metastasis. If you don't see the metastasis, then choose the multiple myeloma. If the multiple myeloma is not seen, then you have to choose the other type, that is known as a osteosarcoma. But osteosarcoma has two types. One is the primary, other one is the secondary. Primary is seen in the less than 20 years of the age. Secondary is seen in the 60 years of the age. Okay, and the factors that is associated with the primary tumor, this is whole from the bone origin only. Okay, this is coming from the bone original, whereas the secondary, it is actually coming from the secondary factors. For example, Paget's disease patient, if the patient is suffering from the Paget's disease of the bone, he likely to develop the osteosarcoma. For those who are taking the teriparatide, okay, this is a teriparatide, which is a drug that we use for the parathyroid hormone analog. This can also cause the osteosarcoma. So if these two associations we can also see, and also those who are suffering from those who are taking the radiation can also cause this cancer. That's why the radiation is causing this disease, and we can consider this as a most radio resistant, because the radiation itself is going to cause the cancer. This is a radio resistant drug, right? Sorry, radio resistant cancer. Next, what is the feature that you are seeing here? So this is the typical features that only associated with the osteosarcoma, that is known as a sunburst appearances. Here you can see this is a sunburst appearances. Okay, Next, this is known as a Codman's triangle. This is known as a Codman's triangle. I hope you guys might have seen, visible for you guys. Right. Next, moving on to the another, that is the Ewing sarcoma. Okay, Ewing sarcoma is involves the diaphysis. Ewing sarcoma is involves the diaphysis, and remember, guys, this will be involving the metaphysis. This will be involving the metaphysis and distal femur. Okay, distal femur is involved. Next, Ewing sarcoma. Ewing sarcoma, which will be associated with the mostly, this will be also involving the femur. This will be also involving the femur, and this will be associated with the translocation of the 11 and 22. 11 and 22 translocation is seen, and on the X-ray, if you can observe, this X-ray is going to show the this kind of pulse. Okay, these pulse is called as onion skin appearances. Onion skin appearances. This is known as a Ewing sarcoma. And what is the positive that you are going to see? When you do the immunohistochemistry, there is a specific marker MIC2, and this is also known as a CD99, that is positive for the Ewing sarcoma. Next, moving on to the chondrosarcoma. Chondrosarcoma is mostly involves the pelvis, and this is associated with the cartilage, right? Cartilage involvement of the chondrosarcoma, and this is highly chemo resistant. If ever you see, that is the chondrosarcoma. Next, moving on to the fibrous dysplasia. Fibrous dysplasia. This is fibrous dysplasia is involves the metaphysis. Sorry, this will be involving the diaphysis, guys. This will be involving the diaphysis, and these fibrous dysplasia is actually due to problem in the congenital. Okay, this is due to congenital, or it could be associated with the developmental problem. Okay, and one syndrome that is associated with this condition, that is a McCune-Bright syndrome. Okay, McCune-Bright syndrome that is associated. And next, the deformity that you are going to see here, the femur involvement, that is Shepherd's deformity. Okay, Shepherd's deformity is seen in this patient. Whenever you see this patient on the histopathology of the biopsy, you are going to see the Chinese letter appearances. Chinese letter appearances is seen in this patient. Next one, that is the osteomyeloma. Osteomyeloma, as I said, this is the most common malignancy tumor, and classically that patients will be having the back pain. Patient is always complains of the back pain, and old people, okay, like men which will be in the 60s or the 70s, they will be presenting with the multiple myeloma. And the specifically on the peripheral blood smear, you are going to see the Rolox formation, and in the HPLC, this is the histopathology when we are checking for the patients, not the biopsy. When we are looking for the immunoglobulins in the electrophoresis method, we are going to see the increased immunoglobulins of the light chains. Increased immunoglobulins of the light chains, which will be elevated. In the urine sample, you are going to see the Benz-Jones proteins. The urines, you are going to see the Benz-Jones proteins. And is the calcium is elevated in these patients? Yes, calcium is elevated in these patients. And what is the X-ray? Classic X-ray which will be showing the lytic lesions. Okay, lytic lesions. We can also say the punched out lesions. Punched out lesions that you are going to see in the multiple myeloma patients. Next, moving on to the classification, some of the important classifications that you have to take note. So the first one is the Gustilo-Anderson classification. That is the Gustilo-Anderson classification. This Gustilo-Anderson classification is divided for the open fractures. Okay, this is for the open fractures. We have the three types. So the first type is a less than 1 centimeter exposure only, and it is clean fracture. Next, second type, this is a skin wound which is more than 1 centimeter and less than 10 centimeters. And third fracture, it is high energy fractures, it is always more than 10 centimeters. Okay, it is always more than 10 centimeters, and this is subdivided into the 3A, that is the multi-fragmentary fracture and segmental fractures is significantly seen. Next, 3B is crush fractures, and 3C, that is a vascular injury, and this is requires the immediate repair for the patients to prevent the bone loss and the amputation. Okay, these are the three different classifications of the fractures. Next, moving on to the Salter and Harris. Salter and Harris, you can remember with the mnemonic of the Salte. Okay, so Salte means S for this is a separated bone growth. This is the first step. Okay, only there will be a gap. Okay, there is a separation. Next, Salter 2 classification, it is above the growth plate. This is your growth plate, and above there is a fracture. Next, Salter 3, this is the lower. Okay, below the growth plate. This is the growth plate, and below that. And Salter 4, it is combined both the growth plate and upper segment and lower segment. Throughout the growth plate that you are going to see Salter 4. And Salter 5, it is like a erosion of the growth plate. That means suddenly the force is both the epiphysis and the metaphysis between the physis, that is compressed. That is the third. And which of the following is best prognosis? So this is having the best prognosis. This can be also have the best prognosis. This is the bad prognosis, and here this is also bad prognosis, and this is the bad prognosis. And the most worst, let's say this is the most worst, the growth plate will be seen in these patients. Okay, that is a classification that you have to remember for the Salter and Harris classification. Next, another important point, that is the avascular necrosis. Okay, avascular necrosis. So in the patients of the avascular necrosis, so what happened? So generally the patients is most commonly the cause will be idiopathic. Okay, so there is no cause, we don't know. Some of our surrounding people also they might have, but this is a very incidental finding. Over the time, if they are build up the pain, then only they are going to find, and on the incidental findings only we are seeing this avascular necrosis. But most common and established, apart from the idiopathic, it could be due to trauma and sudden slip of the sudden tear, which cannot be seen in the postmenopausal patients. So that is seen in the trauma. And also those who are using the misuse the steroid drugs, so the steroid drugs can be seen. And in the children, this is known as a Parthes disease. Children, it is known as a Parthes disease. And also those who are having the continuous exposure to the sea, continuous exposure to the sea, and those who are suffering from the Gaucher's disease, this is a type of the lysosome storage disorder, and also sickle cell anemia. Okay, you whoever associated with this kind of conditions can also present with the avascular necrosis. Next, what are the sites? Okay, the most common overall, it is the femur, and in the femur it is going to involve the neck of the femur. Okay, if there is a neck fracture, I'm not telling this is a neck of the femur, this is neck fracture. Okay, next, second part is a scaphoid bone. Second part is a scaphoid. And if there is a waist fracture, okay, waist fracture. Next, thallus. Thallus also same similar, it is due to neck fracture. Neck fracture. Investigation of the choice is the MRI. And what is you are going to observe here, there will be complete destruction of the bone. Okay, so the supply is not here, so you can see this opacity. So this is going to present in the patients of the opacity. For example, artery is coming like this. Okay, but there is a fracture of the neck. So what happens, the supply is stopped here, so there is a destruction of the bone, that is known as a avascular necrosis. Next, moving on to the some of the important structures and their associated conditions. Let's see one by one. So here you can see this is a clavicle. I have discussed the same image in our anatomy lecture also. So consider this the most common overall fracture in the human body. And what is the location? This is between the junction of two-thirds of the medial and one third of the lateral. One third of the lateral. This is going to be presented in the common fracture site for the clavicle. And what is the treatment? Treatment is 8 bandage. Okay, 8 bandage we recommend for the patient to take. That is seen here. Next, coming to the another fracture. This is your humor, right? And this is your radius and ulna. So what is the fracture location? So this is the condyles, right? Lateral condyle and the medial condyle. So these fracture is supracondylar fracture. This is described as a supracondylar fracture, and supracondylar fracture is common in the children. Common in the children. It could be associated with the extensor type, or it could be associated with the flexion type. Extensor type is most common. That is going to be C. Supracondylar, it is also known as a distal humor fracture also you can say. But what is the artery that is damaged here? The artery that is damaged because we have the cubital fossa here. So brachial artery can be injured in this patient. So the pulse can be disturbed. Next, the nerve. The nerve that is involved in this patient is the AIN, anterior interosseous nerve. And if you don't see the anterior interosseous nerve, then you can mark the median nerve. And if you don't see the median nerve, then you can mark the radial, or if it is ulnar. But the most common is the anterior interosseous nerve that is seen in this patient. The complications are most worst complications will be seen, and one among them is, this is the asked question, the patient is presented with the cubitus valgus. The patient is presented with the cubitus valgus. So cubitus valgus patients, this is also in the other words which is known as a Gunstock's deformity. Okay, Gunstock's deformity due to healing process of the bone damage. Next, another important, the named fractures. One is a Montagia's fracture and other one is the Galeazzi fracture or the reverse Montagia fractures. You have to differentiate between these important fractures. So Montagia fracture, this is upper one third of the ulna fracture, and then we also have the proximal right upper junction that is disrupted. That is for the displacement that has been seen with the Montagia fracture. And the nerve that is involved in this patient is the posterior interosseous nerve. Posterior interosseous nerve. And completely opposite to the Galeazzi. That's why the name is also reverse Montagia fracture. So here it is radial fracture. This is radius fracture. Okay, middle, or we can say midline, and there will be distal junction that is disrupted, or we can say that is displacement is happened. That is a distal fragment that is displaced. And the nerve that is most commonly same posterior interosseous nerve, or you can say this could be also associated with the median or other nerves also. But the most common nerve for the Montagia, that is a posterior interosseous nerve. Next, another two types. This is also similar one, that is a Colles fracture and the Smith fracture. Colles fracture, this is associated with the distal radius. Colles fracture is due to distal radius fracture. Okay, these are the fractures, guys. Next, these distal radius fracture. And how about the Smith fracture? Smith fracture is also distal radius fracture. Then what is the difference between the Colles fracture and the Smith fracture? So in the Colles fracture, if you see, this is the dorsal displacement. Okay, there is a dorsal displacement. In the picture of the Smith fracture, this is distal radius fracture only, but palmar or olar displacement is seen in this patient, right? This is the main differences, and also known as a spoon deformity. Okay, dining forks deformity. And this is the spade, right? Gardner spade. And here you can see this is the Gardner spade deformity. Okay, this is the spoon and this is the Gardner's deformity that you are going to see in the patients of the Smith fracture and the Colles fracture. One Smith fracture is most commonly associated with the osteoporosis patient. Females osteoporosis, they will be having the Smith fractures. Next, lower limb deformities. Whenever you see the lower limb deformities, that is the most common that you have to remember is the posterior hip dislocation or the anterior hip dislocation. Among them, the most common overall is the posterior hip dislocation, where you are going to see dashboard deformity or the dashboard injury in the RTA patients. When there is a driver or the passenger, they will be having this dashboard deformity. And how you are going to appear, how these patients will be appearing. So posterior dislocations, these patients will be this kind of picture that X-ray is given in your examination. What is happening here? So if you observe, this is the lesion, right? This is the dislocation is happened. So the patient in the posterior dislocation, there will be internal rotation. So the leg is came inside, there is an internal rotation. That means there is a abduction, right? Adduction, I mean the middle, coming to the middle side, there is a adduction is seen in this patient. And whatever you are see, whenever this, here you can see this is a dislocated in back side. So this time it is going to be flexed position. Okay, to avoid the pain, the patient will be in the flexion position. Okay, so this sequence is also asked. First there will be flexion at hip, first one, and there will be abduction, sorry, there will be adduction guys, adduction at thigh region and internal rotation. So how can you remember this? With the mnemonic of the Fadir. With the mnemonic of Fadir. This is for the mnemonic. And coming to the anterior dislocation. So anterior dislocation is suddenly the patient is falling from the height. Okay, falling from the height. So these patients which will be having the flexion at hip to avoid the pain and abduction at thigh region and external rotation. I will show the image of the X-ray and the mnemonic that you can remember this one with the Fabir. With the Fabir. Right, here you can see this is a picture, anterior dislocation and external rotation, abduction. Right, this is how it is going to be presented. Next, the limb lengthening and limb shortening, where you are going to see. So the limb will be shortened because it is went backside, and the limb will be lengthened. The limb will be lengthening is seen here in the anterior hip dislocation. Next, another picture in the recent INICT also this question has been asked with this kind of image. So this patient is suffering from the Pott's spine. Okay, this patient is suffering from the Pott's spine. What is mean by the Pott's spine? So Pott's spine is caused due to TB with the hematogenous spread. Okay, with the hematogenous spread. So obviously the patients who are suffered from the TB with the hematogenous spread, so there will be involvement of the most commonly vertebrae. Most commonly it will involve the vertebrae. In that vertebrae, dorso-lumbar is most commonly involved. Dorso-lumbar is most commonly involved. And the patient will be having same symptoms. The one most peculiar symptom is a chronic back pain. Chronic back pain. And the patient might be also having the cold abscess. What is mean by the cold abscess? The abscess is not seen as a pus discharge outside, right? Pus discharge as outside we can't see. And these patients might be also having the paraplegia. What is the paraplegia, guys? The patient is suddenly having the stiffness. So these kind of stiffness, army stiffness, like army person how they stand while they're doing the parade ground rehearsals. So like that, the patient will be having the army stiffness is seen in this patient. And what is the best investigation of the choice? That is MRI. And what is the gold standard, or you can see this is the ultimate step, that is the biopsy. Okay, biopsy has to be done with the CT guided biopsy, that has to be done for this patient. And what is the treatment for this patient? And if you see there is a severe impairment, you have to go for the surgery, and if it is not, then we are going to go for the ATT, that is a antitubercular therapy. Almost we are going to give more than 12 months that the patient should take the TB drugs, that has to be taken by the patient. Next, some of the TB Sika. This is seen in the shoulder. TB Sika is seen in the shoulder, right? And spina ventosa. Spina ventosa is involves the metacarpals. And TB arthritis is going to cause the fibrosis, irreversible damage to the bone. That is the TB arthritis will be, which will be causing the fibrosis of the bone, right? This important points is has to be noted for your examination, right? This is how you are going to see the patient will be having the deformity that can cause the kyphosis, and also the lordosis can be also seen in this patient. Next, another infection, that is the osteomyelitis, is subdivided into the three types: acute, which is less than 2 weeks; subacute, 2 to 6 weeks; chronic is more than 6 weeks. Subacute, either the organism is less virulent, or the patient is having the immune system, right? If this both works, the likely to be subacute is not going to present with the major changes. What about the organisms? So the most common overall is the staphylococcus aureus. The salmonella is seen with the sickle cell anemia patients. IV drug abusers is caused by the pseudomonas. Animal bite, which will be pasteurella. Human bite is due to echinella, and neonates is associated with the group B streptococcus or the E. coli organisms. So how we are going to see the patients with the acute? So acute patients in the MRI, in the early stages, you are going to observe the most importantly the marrow, the bone marrow, which will be filled with the edema. Okay, but on the X-ray you are going to see this periosteal reaction. Okay, this is seen with the periosteal reaction, and this periosteal reaction, when you are going to see around 10 days, this is going to be presented. But the acute symptoms is most commonly the patient will be having the fever. Okay, the peculiar symptom inflammation, that is fever, will be seen in this patient. Next, subacute, you are going to see this lytic lesion. This is known as a other name for this is a Brody abscess. Okay, in the recent last say 2 years, or I think last year only, this question is also asked in Brody's abscess. Next, third one, how you are going to differentiate between the acute and chronic? Because in the chronic also you are going to see the fever, but along with the fever the patient will be having the pus. Okay, the chronic history will be also from the long time, so that will be giving rise to the chronic. And in the chronic you are going to see the two types. One is the involucrum and the sequestrium. Sequestrium is a dead bone, involucrum is a new bone, and to this connected, that is going to be the cloaca. Cloaca means it is the sinus formation from the skin to the bone, so from there you are going to have the discharge. Okay, that is how we are going to see. Sequestrum, you have to do the sequestrectomy, and after the removing this you have to fill the cast or the cement. And when you are doing the sequestrum, you have to see the blood vessels, right? The flush blood has to be seen in the basement, and that sign is known as a paprika sign. Okay, paprika sign. So you have to see the blood while you are dissecting or removing the sequestrectomy. Next, moving on to the another type of the infection. Infections is also very important, guys. Septic arthritis. This septic arthritis is most commonly involved Staphylococcus aureus. The patient will be involving the Staphylococcus aureus, and this is involving the joint space, and if involves the joint capsules, it can cause the destruction. Severe destruction will be seen, and that's why this condition is also considered as a emergency. And you can also look how dangerous it is looking like, right? Very severe erythema is seen in this patient, and the patient can develop the fever, and sepsis also seen in some conditions. And when you are doing the examination is tender and hot. Okay, erythema is seen in this patient. and if it is damaged, it can cause the pus formation also, right? And sometimes it is seen with the STD patients. In the STD patients, it is the gonococcus, and if they are IV drug abusers, same like the above condition, it can be seen in the pseudomonas infection. And what is the investigation of the choice, guys? Arthroscopy. Okay, arthroscopy. And what is the treatment of the choice? Arthrotomy. Arthrotomy that you has to do. Okay, arthroscopy or the orthocentesis that can be done. Orthocentesis can be also done in this patient. Next, these septic arthritis is seen with the children also. In the children, here it is knee. Here it is knee as the most common, but in the children, the most common location is hip. So irreversible damage will be seen in the hip, and that we call as a Tom Smith arthritis. So Tom Smith arthritis is not a separate condition. This is also septic arthritis only. Okay, this is also septic arthritis. Next, I have mentioned here they are the important test and the involvement of the structures that you have to take note. For example, when I say the structures, so let's see the importance of the nerve damages. We have the neuropyrexia and neuroemesis and axotomesis. So what is difference between this? Neuropraxia is a physiological nerve block, right? Neuroemesis, complete neuroma is damaged and disrupted. And axonemesis, the neuroma is intact but it is disrupted. This question is also asked, guys, in the recent INICT. The neuropyrexia is asked. So when I say neuropyrexia, so the most important, this is a physiological and it will settle by itself. You have to do is the supportive treatment. Neuroemesis, this is already going into the Valerian degeneration. You have to do by the surgical fixation only. And axoemesis, it can be regenerated by less than 1 mm per day at the location of the myelin sheath. Okay, that is seen at the myelin sheath. And here in this patient, the Tinel sign is going to be positive. So from the distal to the proximal, you are going to see the Tinel sign, and also motor march will be seen in this patient, right? Axoemesis you are going to see. Tinel sign is not in the neuropyrexia. Tinel sign is seen in the neuroemesis but not in the neuropyrexia. You are going to see the Tinel sign that has been seen in this patient. Next, how can you differentiate? So we will be discussing of the some other important structures, diseases, but before that I want you guys to understand about the how from the labs you can understand which disease is which. For example, let's take rickets. So in the patients of the rickets, how you are going to identify these patients? So the rickets patients or the vitamin D patients, how they are going to present it? Obviously there will be bone pain or the bone growth is not properly seen in the children patients. That is how they are going to present it. So whenever you take the different lab values, you have to do the calcium, and also you have to do the parathyroid hormone. Then you have to check for the phosphorus, and also ALP has to be checked. So how they are going to present it? So in the rickets patients, what is the defect? The vitamin D is not producing, so obviously the calcium will be decreased because the absorption cannot be possible without the vitamin D. So if the calcium is decreased, parathyroid hormone will be increasing, so to compensate the mechanism of the calcium. And the phosphorus, what happens to the phosphorus? Always parathyroid hormone will throw the potassium or phosphorus from our body, so the phosphorus will be decreased. And parathyroid hormone is trying to increase the calcium levels in the body, so while that it will increase the ALP, so the bone formation will be seen here in the patients of the rickets. When I say the patients, those who are suffering from the renal condition, okay, so the renal related osteodystrophy, last, the renal bone disease, in these patients the calcium is severely damaged. Why? Because there is a kidney disease and the bone disease, so obviously the calcium mineralization or the calcium excretion is not properly happening in the body. So the calcium will be decreased in this patient. Again compensatory, the parathyroid hormone will be increased in the patients, and the renal condition is seen. You cannot throw the phosphorus from the renal because the renal disease is existed, so the phosphorus will be built. Despite of increasing the PTH also, the phosphorus is increased in the body. And ALP, always there is a bone inflammation, the ALP will be increasing in the body, right? Next, the patients who are suffering from the parathyroid hormone adenoma. Parathyroid adenoma, if you see, parathyroid hormone will be increased. Because of this adenoma, obviously the calcium will be increased, the phosphorus will be decreased, and the bone inflammation can cause ALP will be increased. Next, the last condition, there is a Paget's disease. In the Paget's disease of the patients, those who are suffering from the Paget's disease, what happens in the Paget's disease? The lytic phase and the blastic phase will be seen. At same time bone is forming, same time bone is resolving. So these patients, mostly the calcium will be normal, PTH will be normal, and the phosphorus will be normal. But 10 times higher the ALP will be raised in this patient. Okay, so these tests that can be differentiated immediately from our question itself. Okay, immediately in the question itself you can differentiate. So I will just keep this here so that you can read later, and other tests that I have to write. Okay, other tests we will be discussing also. So most of the test whenever you do for the nerve injuries, right, book test, format test, or the any OK test, all this will be, we are checking with the different types of the test. And in that, what we are actually checking, okay, that is the question that has been asked in the examination. For example, you are checking for the book test, okay, and the format test. This book test and the format test is done for the ulnar nerve palsy. This is done for the ulnar nerve, and especially in the book test, you are going to check for the adductor pollicis muscle. Adductor pollicis muscle. Next test, that is the card test. Card test. Card test is done for the same ulnar nerve. And what are the muscles that will be involved in the card test? That is the palmar interossei. Palmar interossei. Next, we have the Igawa test. In the Igawa test, also this is about the ulnar, but this is for the dorsal interossei. This is for the dorsal interossei. Igawa test. This four important test is done for the ulnar nerve only. Next, for the patients, those who are suffering from the median nerve, that is a pen test. Median nerve. This is for the median nerve, and this is for the abductor pollicis. Don't confuse here. Okay, so this is the adductor pollicis, this is the abductor pollicis for the pen test. OK sign, we also have the OK sign, right? In the OK sign, we are checking from the median, and more specifically this is for the AIN, right, anterior interosseous nerve. And these anterior interosseous nerve will check the two important muscles, that is the flexor digitorum profundus, and also we are using the thumb for to say OK, right? This is also involves the flexor pollicis longus. This is for the OK sign that you have to remember, right? These are the two important tests that these are the some important tests for the different types of the palsies that you have to be remembered, right? And if I say the fractures and associated fractures, what are the fractures and what are the associated nerve injuries? Fractures and nerve injuries. Okay, let's see. So first, if you have the shaft of the humor fracture, let's say, and humor neck fracture, supracondylar fracture, supracondylar fracture, supracondylar fracture, or condylar fractures only, direct lateral condylar fracture or the medial condylar fracture. And there is a tibial fracture. I'm sorry, there is a tibial fracture, right? tibial fractures is also commonly seen. And even if these fractures are seen, what is the main main nerves that is involved? In the humerus fracture, this is the radial nerve, and in the neck of the humor, this is the axillary, and the supracondylar fracture, as I said, this is the anterior interossei, and here it is the ulnar nerve, both the medial and the lateral, and in the tibial, common peroneal nerve that is involved. And cubital tunnel syndrome, you might have heard cubital tunnel syndrome. So U for U, this is for the ulnar nerve. And Guyon's canal, Guyon's canal. So Guyon's canal is also for the U for U, this is for the ulnar nerve. And carpal tunnel, you all know carpal tunnel is for the median nerve, right? Carpal tunnel is for the median nerve. So we also have the two more conditions, guys. One is the meralgia and other one is the chiralgia. So this is the pain, meralgia syndrome paresthesia or the chiralgia paresthesia. Meralgia is lateral cutaneous nerve, this is for the lateral cutaneous nerve. And chiralgia, this is for the radial nerve, this is for the radial nerve. So these are the direct questions can be also asked in the examination, so please don't forget to read these important points. Okay, this is also can be asked in the examination. Next, moving on to the difference of these conditions. Okay, so this is the final slide that we are going to discuss. First, we will be discussing of the Klippel-Feil syndrome. What is the defect of the Klippel-Feil syndrome? This is the defect in the seen in the cervical. This is seen in the cervical spine, mostly in the cervical spine, due to non-fusion of the specific the vertebrae in the cervical region. And what is the triad that you are going to see in this patient? So the triad that's seen in this patient is a short hairline. So the patient will be having the short hairline, and also the patient will be suffering from the scoliosis and the springal deformity. Springal deformity will be seen in this patient, and the webbed neck. Okay, webbed neck is seen. So basically, whenever you are having the S movements from the neck or the no movements from the neck, the patient might be having the difficulty to perform those. Klippel-Feil syndrome patients cannot perform that condition also. Next, osteoporosis. Osteoporosis is one of the most important. What happens here? This is the quantitative. Okay, this is the quantitative condition. That means one of the bone density is decreased in this patient. It is not about the osteoclast or it is not about the osteoblast. The bone density, the bone mass, the bone structure, you can see the bone structure is completely damaged in this patient. And it could be due to anything. It could be due to mineralization also. The patient might be not having the proper mineralization. The patient might be not having a proper hormonal in the body. So all these conditions can be seen in the osteoporosis patient. And the most common risk, if we say in the females, in our mothers also, that is due to menopause. Okay, so menopause, the estrogen have that effect. If the estrogen is suppressed, it can trigger the osteoporosis. And those who are outside, they are taking the steroids or they are taking the heparin, those who are taking the thyroid medications, this is due to medicine related. And some of factors like smoking, or it could be age and obesity, because obesity can suppress the estrogen in the females, right? Alcohol patients, all these conditions is also associated with the osteoporosis. And who is more risk? Females are more risk than the males. And if ever it is involved, the most commonly it will be involving the vertebrae. Okay, thoracolumbar vertebrae will be seen, followed by the hip, and followed by the wrist. Same with the fracture also. So the first fracture will be vertebrae, second will be the hip, and third will be the wrist. And wrist Colles fracture is commonly seen. And what is the investigation of the choice for this patient? Investigation of the choice for this patient is the DEXA scan with the normal aged female, like 20 to 25 years of the female. You have to check the bone density of the both females. And if it is less than 2.5, if it is minus less than 2.5, then the diagnosis is confirmed that the patient is suffering from the osteoporosis. Okay, osteoporosis is confirmed in this patient. And coming to the treatment, So how we are going to treat this patient? So the treatment for this patient is the drug of the choice is the bisphosphonate. Okay, bisphosphonates is given for this patient, but bisphosphonates is going to how they are going to act. They are going to act on the osteoclast by they are going to increase the resorption of the bone so that the bone density will be not be decreased. And other drug we can give, that is a teriparatide. As I said, it can cause the osteosarcoma. This is the PTH, parathyroid hormone receptor analogs. It will be increasing the parathyroid hormone, so the bone resorption will be seen in this patient. This is the bisphosphonates and the teriparatide. And the bisphosphonates, this drug is having the specific side effects. That side effect is the atypical fracture. So that's why we have to take this drug as a honeymoon period. Also, we have to keep this for this drug. For example, you started this drug for the 1 year, then you have to give the gap for 2 years, and then you can resume this drug another for 1 year. So this will be like a vicious cycle that we are going to see 1 year gap and other year. And apart from the atypical fracture, severe gastritis also seen with this patient. So the patient has to take the 1 glass of the water, then take the tablet and another 1 glass of the water. So it can cause the gastritis also. This is the overall review of the osteoporosis. Next, coming to the another picture here, this is the X-ray, especially the newborn patient. And this newborn patient is having the multiple fractures and multiple healing processes is seen in this patient, right? Multiple fractures and multiple healing processes seen in this patient. Even the skull fractures is also seen. So this condition is known as a osteogenesis imperfecta. So this condition is known as a osteogenesis imperfecta, and this is an autosomal dominant condition, involves the COLA1 gene. And what happens these patients? So these patients will be having the sclera is very much thin. The sclera will be thin, so it will be looking, the venous will be more prominent in this patient, so the blue sclera will be seen. And recurrent fractures. Okay, even when you check these patients in the mother womb also, you are going to see the recurrent fractures and multiple healing. They heal by themselves also. So that is a bullous sclera and multiple recurrent fractures will be seen, and patient will be also suffering from the dentition defects. Okay, dentition defects will be also seen in this patient, and it is associated with the autosomal recessive also. That is a osteogenesis type 2, but it is severely fatal. The patient can die also. This is the osteogenesis imperfecta, which is also known as a brittle bone disease. This is also known as a brittle bone disease. Next, so from this picture you can see this is some length and here is the other length, and same here there is a dislocation has been seen. And what is this condition, guys? This is the DDH. What is mean by the DDH? It is a developmental displacement or the developmental dislocation of hip. Okay, this is seen mostly in the females, then the males, and first child. The risk factor that is associated is the breech delivery. The patients, those who are having the breech delivery, they will be having this condition. And this test is known as a Alice test. Okay, the limbs will be having the different lengths. And if the patient is less than 3 months, let's say that the patient is less than 3 months, then we are going to do the test of the Ortolani and the Barlow. This is the Barlow test. Okay, Barlow means inside, and this is the Ortolani, this is out. And where you are going to do, this is the Ortolani, this is the Barlow, and in the Barlow you are going to dislocate, and here you are going to reduce. Okay, this is the difference between the Barlow and Ortolani test for this patient, right? So basically we are not going to do much of the differentiation for this patient. The investigation of the choice is, as the patient is children, we have to do the ultrasound, and from the childhood itself we can go for the some of the for example, we can use the Paulic brace. Okay, the patient can be given the Paulic brace, and if the patient is 6 months, we can start do the reduction procedures, and if the patient is more than 3 years, then we can go for the pelvis surgery, that is a osteotomy. Okay, osteotomy can be considered for this patient. If the patient is 10 years and patient is healthy, then we can go for the hip replacement surgery. Okay, hip rod replacement surgery is also done for this patient. This is for the development dysplasia. And next, here the two different x-rays has been given. This is the patient of the scurvy and this is the patient of the rickets. So scurvy is a vitamin C, this is the vitamin D, right? This is the vitamin C is decreased. So what are the bone changes that you are going to see in these two conditions? In the patients, those who are suffering from the vitamin C deficiency, this is differentiated as a different zones, guys. For example, you can see this is the diaphysis. I'm sorry, this is the epiphysis. This is the epiphysis, this is the physis, and this is the metaphysis, right? So in the metaphysis, you are going to see the subperiosteal hemorrhage. Okay, this is the subperiosteal hemorrhages between the periosteum and the bone. Next, in the physis, you are going to see the scorbutic zone. This scorbutic zone, like this. Okay, the scorbutic zone, the inflammation is seen in the physis zone. Next, same in the physis zone, there is a dense zone that will be seen, which is known as a white line of the Frankel. Here you can see this is the white line of the Frankel, which will be differentiating between the epiphysis and the physis. And this is also dense of the calcification physis. And in the epiphysis, you are going to see this ring. Separate rings will be formed and the space is increased. This space of the ring is occupied, that known as a Wimberger ring, that is known as a Wimberger ring, and this is known as a Pelcom spur. This is the how the scurvy patient will be presented. And coming back to the rickets patient will be having the fraying, and rickets patient will be having the splaying and also cupping. Okay, this is how the rickets patients will be presented, comparing to the differentiation between the bone changes in this both condition, right? This is the difference between the scurvy and the rickets. Next, moving on to the another condition. This is the osteopetrosis. This is the osteopetrosis, which is known as a marble bone disease. Marble bone disease. So what is the osteopetrosis? If you can observe this structure, this is highly opacity, right? Severe opacity is seen in this X-ray, right? The density of the bone is too much. So that is due to osteoclast. So the more and more osteoclast is increased in the patients of the osteopetrosis, and this going to cause the increased bone density. This will be increased bone density, and also the patients is more prone to fractures. Okay, multiple and repetitive fractures will be seen. So the differentiation between the osteogenesis imperfecta and the osteopetrosis, this will be more diffuse and more opaque, and the patient will be having the multiple repetitive fractures will be seen, and even the adults will be also sometimes presented to the condition. And along with that, there will be having the SNHL, which is the sensory neural hearing loss, and complete WBC and RBC, and along with that platelet will be also decreased. That means pancytopenia is also seen, and also hepatosplenomegaly will be also seen in this patient. Next, back to the important one. This is the Paget's disease. Paget's disease of the bone. So the Paget's disease of the bone, which will be having the three phases. First, it will be having the osteoclast, okay, followed by the osteoclast and also osteoblast. Okay, next, the final phase will be the osteoblast. So this is how the first phase, second phase, and third phase. So continuous inflammation and production will be seen with the different types of the cells. So the patient will be having again the chronic pain. The back pain will be mentioned by the patient. So the back pain will be mentioned, and old age people. These old age people, and in the olden days, how they have described is the old age people who used to wear the to cover their bald head, they used to wear the different caps. So these patients will be changing of the recurrent caps. Okay, recurrent caps will be seen, and also the cranium is so swelling that can cause the cranial palsy also. Cranial palsy also, such as 2, 5, 7, okay, 10. Like this cranial nerves is also completely the patient will be having the cranial palsy due to compression of this bone swelling, and this swelling we describe as a cotton wool or pod skull. Okay, pod skull. The measurements also going to have, and here you can see this is the thickening. Thickening will be also seen in the late stages of the patient, and it can cause the malignancy. That malignancy is known as a osteosarcoma. Osteosarcoma. That is how the patients will be presented with the Paget's disease. Next, this is the primary parathyroidism. This is the primary parathyroidism condition. In the patients, those who are suffering from the primary parathyroidism, this is due to increased PTH, which is secreting from the parathyroid adenoma. Okay, parathyroid adenoma. In the patients of the parathyroid adenoma, how we are going to do? Investigation of the choice for this patient is the system scan. System scan will be done in this patient, and these patients will be having the increased PTH and increased calcium and decreased phosphorus that will be seen in this patient, right? And on the X-ray you are going to see this brown tumors. So what is the meaning by the brown tumors? This brown is due to hemosiderin. Okay, hemosiderin is generally looks brown, so that's why this is named as a brown tumors. So this is the hemosiderin deposits in the periosteal regions that you are going to see in this brown tumors. Next, this is a mental sign. So this is the Martel sign. This is the Martel sign. In the patients of the Martel sign, this is seen in the acute and chronic gout. And also, if you observe, this is the classic lesion, right? So the first MTP is the most commonly involved in the patients, right? This is a tophi that is going to do the subperiosteal bone resorption, which is seen with the acute and the chronic gout patients. Next, moving on to the some other conditions. Here you can see this is the CTEV patients. Okay, CTEV patients. So this is the one I have mentioned here, guys. Sorry, where is it? Paulic brace. So this is the Paulic brace. The picture is displaced here. This is the Paulic brace used in the CTEV deformity patients. CTEV patients deformity you are going to use. So this is the condition of the CTEV. Okay, this is the condition of the CTEV. What is mean by the CTEV, guys? This is the cavus talipus equinus varus. Okay, this is the deformity. This is the deformity of the patients who are suffering from the cavus, talipus, equinus and the varus. And what is mean by these definitions? Cavus, talipus, deformities. Let's understand that these different types of the definitions. First, what is the equinus? Okay, equinus means it is in the plantar flexion. Equinus is the plantar flexion. Next, calcaneus. Calcaneus. This is the dorsiflexion. This is one of the neat PG PYQ. Next, valgus. Valgus is nothing but it is a abduction plus eversion. Okay. Next, varus is inversion, opposite to that, and adduction. Next, cavus. Cavus. Cavus is high arched. Cavus is high arched foot. And next we have the planus. Planus. Planus is flat foot. Flat foot. So this is what the patient will be having the different types of the descriptions when we are diagnosing the these CTEV patients. So the most common will be the cavus, talipus, equinus and the varus. This is the definition for this condition. So most commonly this is seen with the male patients. Again this is seen with the breech conditions. Okay, again with the breech conditions, most commonly involves the bilateral, both limbs will be involved, and the most common cause will be idiopathic. Idiopathic will be seen in this patient. And investigation of the choice is the X-ray. Investigation of the choice is X-ray, and in that X-ray you are going to see 20 degrees angle, 20 degrees angle that will be decreased where at the thalocalcineal angle. At the thalocalcineal you are going to see this decreased angle. That is how the patient will be presented with the condition of the CTEV. And in the CTEV, how we are going to manage? This is how we are going to manage. This is the Dennis Brown splint. Okay, Dennis Brown splint. Until the patient is walking, we can do this Dennis Brown splint. Then there will be separate shoes, CTEV shoes. Then we can use that, and after a certain age we can go for the surgery of this patient. That is a Dennis EV shoes. Next, this is the condition, that is a Parthes disease. Parthes disease, also other name is a leg calve Parthes disease. This is the avascular necrosis in the femoral epiphysis. In the femoral epiphysis, this condition is seen. This is the Parthes disease. Next, coming to the another important points of the Parthes disease, this will be involving the femoral epiphysis. That is a one point. Another name of this is the leg calve Parthes disease. Next, what are these conditions, guys? So this is due to most common arthritis. Most common arthritis, non-inflammatory. So by this time you have to already getting into your mind what is this condition. So this is the osteoarthritis. This is the osteoarthritis, right? And these notes that you are looking here is the whenever they are involving the dips, these are the dip joints. These notes are known as a Heberden notes. And if they are involving the pip joints, okay, if they are involving the pip joints, then we call this as a Bochard notes. How can you remember? HD, BP. Okay, that's you can simply remember. On the X-ray, you are going to see the space narrowing. Space narrowing is seen, and also the patient will be having the sclerosis, subsclerosis, and osteophytes growth. Osteophytes growth will be seen in the patients of the osteoarthritis. Next, this condition, the patient is having the fingers on the ulnar side, whereas the metacarpals on the radial side. So what is this condition? This is the rheumatoid arthritis. This is the rheumatoid arthritis and most inflammatory type. This is the most inflammatory. That's why we call this another name, this most inflammatory, seropositive. Seropositive. Females, young, who is having the rheumatic factor free and HLA association and anti-CCP positivity will be seen in this patient. This is the Botner's deformity. This is the pip. This is the dip, right? And same as here. This is the dip and this is the pip, right? So how is this deformity is seen in this condition? So for example, if you see, this is the Botner's deformity. So how it is like this, right? So at the pip joints, it is extension, and compensation, the dip joints is doing the flexion. And swan neck deformity, what happens? The dip joints is doing the flexion and the pip joints, sorry, opposite this. So the pip joints is actually extending. This is the extension and pip joints is flexion. That is seen in the swan neck deformity. So the involved joints of the rheumatoid arthritis is actually pip joints, not the dip joints. Okay, the pip joints is involved, and the most common is MCP joints. This is the most common. Whereas in the osteoarthritis is the most common involved is the dip joints. Okay, that's why you can see the notes is also involved the dip joints, but the MCP joints is paired. Same as here. Here the dip joints is spared. So dip joints is spared here. So some of the important points and remaining points of the this arthritis and everything we will be discussing in the medicine, guys. Next, some of the important test, especially the sports test, that you have to take note. What are the meniscus, what are the involvements that has to be taken note. So Tinel test is done where? Tinel test is done for the nerve damage. Nerve damage, we are going to do the Tinel test. Next, Fallon test. Fallon test is done for the carpal tunnel syndrome patients. Fallon test is done for the carpal tunnel syndrome test. Next, Finkelstein test. Finkelstein test is done for the tenosynovitis. This is done for the patients of the tenosynovitis. Next, Addison test. Addison's test. This Addison's test is done for the thoracic outlet syndrome. Thoracic outlet syndrome. And also other test that we are going to do here is the Roos test. Okay, Roos test. And Haman sign or the Haman test. This is seen in the DVT patients. This is seen in the DVT patients. And next we have the knee impingement test. Knee impingement test, and this is done in the impingement syndrome. Impingement syndrome, like the most commonly supraspinatus injury. Supraspinatus injury patients, we are going to see these patients. Next, Cousins test. Cousins test is done for the condyli. Okay, condyli, lateral condyli, we are going to do for the Cousins test. And we are going to do the valgus test and varus test. So valgus test is done for the medial collateral ligament and varus test is done for the lateral collateral ligaments. Okay. Next, coming to the crucius ligament. Crucius ligament anterior drawer test. Anterior drawer test. This is done for the anterior crucius ligament and posterior drawer test. So the name itself tells this is done for the posterior type. This is the posterior crucius ligament. And Lachman test. Lachman test is also done for the anterior crucius ligament that we are going to do. Next, the last one. This is the PYQ McMurray test. Sorry, McMurray test. McMurray test. This is done for the meniscus and most commonly medial meniscus. These are the some of the tests that you have to remember for the examination, guys. And always remember, at least from this all the PYTs, if you read also, you can easily answer the orthopedics. Orthopedics is a very easy topic, so please do revise once again and read all these important topics. And though if you haven't watched the previous videos also, please do watch. It will be really helpful for you in the final examination. And until then, see you guys. Those who are new to this channel, please do subscribe and share with your friends, and please do like this video so that it will reach the more students and they can benefit from the preparation from this videos. So until then, see you guys. Happy preparation. See you all in the next video.